to welcome you to the October edition of Lunch with Docs PD. My name is Andrea Miriam. I work for Parkinson and Movement Disorder Alliance. We are the group that puts on this monthly program. It's a chance for us to bring the leading minds in movement disorders, the Parkinson's specialists, who are neurologists with advanced fellowship training in Parkinson's, to bring them directly to your living room or your kitchen, or I see lots of your faces all in your homes looking comfortable. So it's our chance to pipe them directly into your home so you can hear about aspects of Parkinson's directly from leading movement disorder specialists. And then we want to make sure that you're able to apply the information that we cover to your own life. Information without application is just trivia, right? So in the first portion, make sure to think of what we're learning about in relation to your own symptoms. We highly encourage and recommend questions.
Hi, this is Ann with the warranty department. Our record shows.
Hi, man, those spam calls find me everywhere. So it's your chance to be able to ask questions and apply Parkinson's knowledge directly to your own life. So let's see. I don't know how many of you know my colleague, Rebecca. Rebecca, could you wave to us? Rebecca's our digital programs manager, and she has her feline assistant there. I always like to see a cat on the desk. So Rebecca, are we all set with Dr. Reed and ready to go with audio and video and everything?
I think so. Dr. Reed, can you hear us?
Yes, I can hear you.
Great.
Can you hear me okay? I'll hold it closer.
Mm-hmm. That sounds wonderful. Well, welcome, Dr. Reed. So everyone, this is Cynthia Reed, MD. She practices in Tucson, Arizona, and so excited to have you, do a deep dive into how Parkinson's can affect the urinary system, and really shed some light on this often under-discussed aspect of living with Parkinson's. So I will turn the floor over to you, Dr. Reed. Thanks so much.
Okay. So thank you very much for joining in today, and thank you very much to my husband. Today is an administrative day, so I just got out of the shower, but he kept me fed and watered today, so I could get ready for this. Let me share my screen with you because I've got some slides to show you. PowerPoint. Is it coming up? There we go. Now can I just do view the slides and it should work maybe?
Absolutely.
View. Show. Where's slideshow? Well, is that big enough? I can see it.
Slideshow at the top. It's right next to.
There we go.
Yeah. And then from beginning would be our current slide.
There we go. Okay. So we're going to talk today about urinary dysfunction. Are these little people at the side on your screen, or I can minimize that? Okay, there. So we're going to talk about urinary dysfunction, and specifically in Parkinson's disease. First of all, I'm going to show you what a bladder looks like normally. So are you able to see my little arrow here or not?
Yes.
You can. Okay, so the big tank or holding spot of the bladder is kind of shaped like an upside down balloon, and this top muscle has a name, the detrusor muscle. So that's one big part of how we store and empty our bladder. The other big part is this part down here. This center tube is actually the urethra, which is where the urine comes out of our bodies. But there is a muscle here in the wall that's called the internal sphincter that helps to close it off to keep it from leaking. And there's a muscle on the outside called the external sphincter. And that also helps squeeze it shut like a purse string so that the bladder doesn't leak urine out of it. There's also these two spotted areas on either side that are representing the pelvic floor muscles. And those muscles also work to help squeeze all this shut and keep everything from leaking. So this view is just showing the difference between a man and a woman. Over here is the woman, and she's got her bowel back here, and the uterus with the vagina is in between, but then the bladder is up front. And, whoops, back one, user error. And then this is the pelvic floor muscle for her. The difference in a man, I get grief, I've got a touch screen. The difference in a man is that this area here is the pelvic floor muscle, but right above it you see this extra spot. That's the prostate. And so that can come into play and cause additional problems for men that you don't see in the women, because it can get enlarged and block the opening to the bladder. So here on the left is a bladder that's filling and it's holding urine. And so this upper muscle here has to be relaxed in order to let it fill. If it's tense or tight, it's not going to let the urine in and let it fill. And actually what I didn't mention before is there's two little tubes up here that kind of look like antennas on some of the drawings I have. And those antennas are actually just the tubes from each kidney that come and empty into the bladder. So the urine comes from the kidneys up top, down into the bladder, and then it's supposed to hold here. And so in this side, the holding phase, both the internal and external sphincters are squeezed shut, and that keeps any urine from leaking out. On the right side, this is the diagram showing the bladder is emptying. And this muscle can contract and help push the urine out of the bladder. And at the same time, these external and internal sphincters at the neck of the bladder, they have to relax in order to let the urine out. A normal bladder holds about 400 to 600 milliliters of urine, which would be about 2 to 3 cups of urine. And a normal bladder will empty about 4 to 6 times per day. And so anything where you're emptying 8 or more times a day is definitely considered abnormal, and it's a pain. It's difficult for life. Another thing about this is when the bladder empties, it should be, here's another picture of the same thing. Actually, let me go back for one more thing though. When it empties, it should be pretty close to completely empty. Normally, there's only 50 milliliters of fluid left, which is just a very small amount. Anything greater than that is considered a residual. And if there's leftover in here sitting around, it's like it becomes stagnant. It's like I've heard people say the urologist described it as a cesspool where bacteria can harbor and they just love growing in the urine and you get more UTIs. So complete emptying is a big part of proper bladder function. Okay, now we'll go to the next one. This diagram is just showing the storage and the emptying again, but it's actually kind of showing you how these muscles here have to contract and this one has to relax for one phase, and it's just the opposite for the other phase. This one has to contract and tighten up, whereas these have to relax in order to empty. Anytime that those aren't coordinated, you're getting problems. You can imagine if everything's squishing all at one time, you're going to get a strong sense of urgency that you got to go, but you can't do it. So let's go on. This is actually the cycle showing the bladder filling. So the pelvic floor again has to be closed. The urine starts filling up the bladder. Once it gets about half full, that's when you get your first sensation to void. However, it's only half full, so you shouldn't have to listen to that. You should be able to inhibit the urge to urinate until you can get to the bathroom or until you have a break in your meeting or whatever. After that first sensation to void, if you just keep waiting, it should allow you to fill further without any spasms of this upper muscle to give you problems. And so it fills all the way up to anywhere, again, 400 to 600 milliliters. Often during the daytime, it'll fill to 300 or 400 milliliters, so a lesser amount. And at night when you're sleeping, it should be able to fill up to about 800 milliliters. So the difference is like up to 2 cups during the day and up to 4 cups at night. But again, as you all know, sometimes the system doesn't work right, and it doesn't hold that much before it gives you the urge to go. Let's see, that's just, we already talked about that one. So in a man, this is the difference in a man. His bladder has a prostate surrounding the urethral, the urethra tube that exits the bladder. So as a man gets older, they can get an enlarged prostate, which squeezes on that urethra, the external tube, allowing the urine to exit, and it gets pinched shut. And that develops a whole unique set of symptoms for men, like hesitancy starting and stopping, or you can't empty. And so those things in particular have to be evaluated by the urologist, and they have to decide whether or not that's something that might warrant a surgical procedure where they go in and they do a roto-rooter, in essence, to open up this space again. There's different kinds of incontinence. When the bladder wall, and oops, here we go again, my finger is sticking on the keypad. When the bladder wall and the external and internal sphincters don't coordinate, that's where you get these types of incontinence. This kind of, sorry about this. The one on the right is the most common in Parkinson's. It is where, even before the bladder is full, the wall of the bladder here has spasms, and those spasms tell your brain, oh, I need to empty, even if it's not full. And so that's where you have urgency and frequency. The second one, the middle one, is what's actually most common in younger adults, where they might have just weakness of the sphincters and weakness of the pelvic floor, and that weakness contributes to any time you cough or you laugh or put any pressure in your abdominal area, the strength of these muscles is so weak that it can't hold the urine in. And so that's just little bits leaking out. This third one over here is not so common, and that's from something like the prostate, where the prostate is blocking or something blocks it. Good grief. And you need to get a mouse. And it keeps the bladder from emptying properly. And so that's a big problem too, because if you can't empty your bladder, you're back to getting urinary tract infections. If the bladder holds, if it were to be so constricted that you can't urinate at all and you waited too many hours, it could overfill, and that actually damages the bladder wall, so that then it's not as useful, from then on. So you have to be careful about, if there's a time where you've gone for too many hours without being able to urinate, you need to go into the emergency room and they need to put a catheter in there and let that urine leak out, or let it out, so that it doesn't stretch out the bladder wall too far to the point where it's a problem. So in Parkinson's disease in specific, there's two big problems. One is the spasms of that bladder wall that gives you some urgency, some sense of urgency that I have to go now, even though it's not full. And the second thing is actually the sphincter, the sphincters being slower to respond. So kind of like your arms and legs are slower to move because of bradykinesia, the bladder sphincters are slower to open. And so that can cause problems when you're trying to start urinating. The urgency and frequency then are the two of the top things that those upper bladder spasms and sphincter slowness cause. Urgency, again, you have the sensation you have to go, and it's hard to get there in time. And then frequency is more than, like 8 or more times in a 24-hour period, or particularly at night. If you're over 65, it's defined as twice as normal, more than twice is abnormal. And that actually is called nocturia, which is the bottom word there. And then the urgent continence. So if these symptoms are all happening and you cannot get to the bathroom in time, that's going to cause the incontinence. And the most common one is the bladder spasming, making you think that you have to go. We already did that one, we already did this one, and we already did that one. But again, it's just showing the anatomy of everything. Oh, maybe I'm going the wrong way. User error. There we go. Causes of these urinary dysfunctions or urinary symptoms. One is that the bladder wall is overactive. The second one is a huge category, medication side effects. There are all kinds of medications other than for Parkinson's that have effects on the bladder and make it more likely to spasm. There's also some of the Parkinson medications that can have some spasming effects. It's any medications that have anticholinergic properties. The various forms of amantadine, the new Gocovri and Osmolex that are forms of extended release amantadine. Those are examples. Some older medications used for, say, tremor in particular or rigidity, benztropine, which is cogentin, and the other one is trihexyphenidyl, which is artane. So if you recognize those last two medications, a lot of people are not using them much anymore because we have so many better options that are newer, but also because of cognitive side effects of them. But reviewing your medication list with your doctor is important for looking for sources of these urinary symptoms. Sometimes patients with levodopa will actually have worsened symptoms when their levodopa is wearing off. So at the end of the dose, before they're ready to take their next dose. So if you start noticing the timing correlates with that, then you just need to treat the wearing off to help those bladder symptoms. The next one is decreased mobility and decreased activity. So as far as decreased mobility, we're talking about with the Parkinson's, you're slower moving, your balance isn't as good, and it's hard to get there, physically get to the bathroom in time to prevent incontinence. And as far as decreased activity, the less that you move around during the, say somebody is a couch potato, okay? They're not moving much. The tendency is for their legs to get swollen and for fluid to retain in their legs. And when they lay down at night and the legs are elevated, that takes gravity out of the picture, and finally the kidneys are able to filter all the blood, and it produces all your urine at night. Another thing about decreased activity is just, it relates to blood pressures. If you have low blood pressure during the day, then your kidneys really aren't getting enough blood pressure, or we call it perfusion, to do their job of filtering the blood. And so, again, once you go to bed at night and you're laying flat, then gravity is no longer affecting things, and your kidneys get much better perfusion, and now they get to work, and they start filtering, and they filter, and you get up multiple times at night. Prostate disease in men, we talked about that already. And actually, urinary tract infections can be both a cause and an effect. So if your bladder isn't emptying and you have some pooling of the urine, that's, like I mentioned earlier, it's kind of like a cesspool that can grow urine infections. But if you're a person that has not ever had any urinary symptoms like of incontinence, or you have a sudden increase in urgency or frequency, that could be the only symptom that you have that you actually have a urinary tract infection. So whatever your baseline is as far as symptoms, you have this sudden increase, and so that would be a worthwhile time to get checked for UTI. Once the UTI is treated, in that case then, generally the symptoms go back to their normal amount. When people are younger, another thing about UTIs, when people are younger, they pretty much know when they have a UTI. They've got the pain, the urgency, the discomfort, maybe blood in the urine, but you don't always get those obvious symptoms when somebody's older. It might just be the exacerbation of their baseline urinary symptoms of urgency, frequency, and incontinence, and it also might just be that the urine turns darker or cloudy or starts to smell much stronger. And those are things that a care partner can take as clues. Maybe we need to check for urinary tract infection. One other aspect is that urinary tract infections can take somebody that normally seems cognitively intact without any hallucinations or with very few hallucinations, and just the UTI itself is a strong enough stressor on the brain that the person then gets confused or gets hallucinations where they never did before. So that can be another signal to go out and get checked for a UTI. So consequences, UTIs we just talked about. Another one is because of people having the urgency and trying to rush to the bathroom, a consequence of that is falling and having fractures. So it's something that really does need to be addressed, if at all possible, and at least improved, if not fixed, to prevent that. Dehydration. Especially if people are having nocturia or urination at night, frequent urination at night, the tendency is, well, I'm just not going to drink. And so people get dehydrated. And if you're dehydrated during the day, your kidneys, again, they don't have enough blood flow and pressure to be perfused properly so they can empty out the toxins out of your blood. And so it happens again at night. Also, dehydration is another reason people can go from rather normal cognitive function with few to no hallucinations, and all of a sudden they're confused, they're hallucinating, having all kinds of problems like that. And it could just be simple dehydration. Actually, I didn't put it in here, but there's a new product that I just learned about a few weeks ago that the World Health Organization uses for dehydration in other countries. It is called Liquid IV, and it's a powder it's in single-use packets. It is available from Costco. Online the other day, it said even CVS had some, and that Liquid IV is quote unquote, an electrolyte powder, but it's not equal to electrolyte drinks like Gatorade or Pedialyte or things like that. It has some proprietary technology in it, which I have not figured out. I've not been able to find the science behind it, but it has some technology that acts like a volume expander. So what happens is if you have a cup of water and you pour your little packet of liquid IV powder in it, stir it up and drink it, it's supposed to make it as effective as if you had drunk 2 to 3 cups of water. So that can help. And I've had some patients that have already tried it and have had really good success with it. The one caveat I would say on it, though, is that absolutely, absolutely do not replace liquids you're already drinking with the liquid IV and say, okay, now I can drink even less, because that's just going to be very hard on your body and your kidneys to not have enough fluid overall. You need a certain amount. And I'll go over later what the normal amount is of fluid. Well, actually, I can say it now. On average, a recommended amount is up to 2 liters. And then we'll come back to that and explain it more. Some more consequences of having these urinary symptoms is having odors from urinary leakage, urinary accidents, and increased burden of care because of having to clean up and change clothes all the time or change bedding. It's actually an increased risk for, going into a SNF or assisted living or something, so institutionalization. Also, depression can be caused by these symptoms, social isolation. People tend not to want to go out, and even avoiding sexual intimacy. And of course, because of nocturia, lack of sleep. So we definitely want to do something about this. For a workup, since I'm a neurologist, I very often use the primary care doctor and the urologist to help out in this whole thing. I don't try and take all of this on myself, but one of the first things is to consider urinalysis to see if there's an infection, and then get a referral from a urologist if needed. They can look at avoiding diary, where you've written down how many times you voided, whether you had urgency when you voided or what. They can do an ultrasound of your bladder to see how much is left after you empty. Is it okay or is it too much? They can do pressure studies of the bladder. They can look inside the bladder with a cystoscope to make sure that there's nothing wrong, and they can help a lot with medication recommendations. I don't know all the ins and outs of all the different medications. I'm just going to mention 2 later. So strategies, what can you do? The first thing is behavior modification. I'll go into this in more specific, each part of it, but it includes things like going to physical therapy. Physical therapists, some of them are trained in bladder issues and can help you deal with that. Another one is dietary changes, timing changes of different things. Medications can be used if behavior modification isn't enough. PTNS is a type of a nerve stimulation procedure, which I have a slide of. I'll show you. They can give you Botox into the bladder wall so that it doesn't spasm as much. And so that can help. And then as a last result, if those things don't work, you can have surgery. One of them is to, again, implant a nerve stimulator. And the other one is for men. If the prostate's an issue, they have to do the little Roto-Rooter TURP, T-U-R-P procedure. So some odds and ends here. One is, let's see, do I not have, let me check my slides. Oh, okay. Taking a nap in the afternoon might actually be beneficial for some people. A lot of you might already know, well, I should elevate my legs at points during the day to help from the swelling, and maybe that can help get my kidneys going. But it kind of needs to be where the legs are equal to head height. So laying down is doing a much better job than just sitting in a recliner with your feet out. And so taking a nap in the afternoon can jumpstart your kidneys to allow them to filter some of your blood and produce urine in the afternoon and evening instead of waiting till overnight. Constipation is a huge thing where sometimes the pelvic cavity is so full of stool that that's pushing on the bladder. So simply treating constipation, the biggest things for that, number 1, 2, and 3, probably drink enough water. Activity, exercise helps move the stool along. And then eating enough fruits, vegetables, and fiber in the diet. So those are the big things. Let me. Hello?
Now you're
Hello?
back.
We can hear you.
Thank you. Oh my gosh, my brother. All right. Bladder retraining is something that can be done with the urologist or with a physical therapist. And that can include both voiding schedules and urge suppression strategies, as well as things like the Kegel exercises or pelvic floor exercises. So voiding schedules are timing your voiding so that you go before you're going to get the urge that you can't resist. So if you're having, say, an urgency to urinate every 2.5 hours and you can't hold it and you're leaking or having an accident, then just scheduling urination at 2 hours instead of waiting to 2.5 hours. The urge suppression techniques, I'm not going to go into those because I'm not trained in that, but they can help you learn how to train your bladder to hold for just a little bit longer. So it's kind of like back when I talked about how the first sensation of needing to empty your bladder could occur as little as 100 milliliters of fluid, and yet the bladder is supposed to hold 400 to 600. So if you can ignore that first urge, the bladder should be able to turn that urge off and fill further. But part of that could use training. This is a diagram showing the benefit. This is before bladder or pelvic floor exercises like Kegel exercises. If these muscles are all weak, it's not going to be able to hold the bladder shut. So whether it's spasming of urgency or whether it's stress of pressure pushing down on the bladder from coughing, you're going to get leakage. Whereas after you do the Kegel exercises, these muscles are much stronger and they assist in keeping the bladder closed. This is a big, messy slide. I've got a kind of a cleaner list on the next slide. This is actually from a website, the urogynecology website for the University of Colorado. And if you were to Google bladder irritants or things that irritate the bladder, something like this will come up. And you can see just how many things are on this list. And how can you possibly get rid of them? Basically, what the recommendation is to be aware of all these and try and cut back whatever you can do without, and then one by one add them in and see if they cause your problem or not. Just because something is on this list does not mean that it's going to cause you a problem. These are just common ones that have been gathered from everybody that has problems. So a little simpler list is this one right here. It's a little bit more straightforward. So the first one is caffeine, which includes coffee and tea, and even people like me, chocolate. There's a few things that you can know about coffees and let me see if I can find it here. There's a difference between dark roasted and not dark roasted. Let's see, so the darker the roast, the less caffeine is present in ground coffee by volume. However, I guess, so just that. If you use a darker roast, it's better. The decaffeinated beans tend to lose their intensity of brewed flavor. So if you use a darkly roasted decaffeinated bean, that might help make up for the difference that it's decaf and not as intense. So a darkly roasted decaf might be a good middle ground. Tea has about half the caffeine of brewed coffee, but the darker the color of the tea, the more tannins that it tends to contain, and tannins are something that are also in wines that tend to irritate the bladder. So that's just something to know. Alcohol is something that irritates the bladder. Anything carbonated, soft drinks, artificial or natural sweeteners are irritating. So are any of the processed foods with artificial ingredients. Citruses such as oranges, lemons, limes, the citric acid is irritating. Anything with tomato in it, spicy foods, and onions, mainly in the raw form, are bothersome. So again, it's just trying to decide how many of these things can you eliminate initially, and then if you notice improvement, then add the things you like back in one by one over the next few weeks. So this is a specific kind of list of behavior modification from another neurologist that had a talk online about bladder control, and he was from the Parkinsons Canada group. So there's up to 2 liters of total fluids per day. The 2 liters is all dependent on who you are, what you do. Are you outside sweating in the Arizona sun? Are you sitting on the couch all day? Constipation. If somebody is constipated, you don't want to limit your fluid intake because that's going to exacerbate constipation. Also, if somebody has any kidney problems, then depending on what the doctor says, you're not going to want to limit your fluids. But anybody that's not got any reason not to make those changes, the recommendation is actually up to 2 liters of fluids per day. And what they mean is they were referencing the shows like Oprah with Dr. Oz and other shows on TV that keep saying, drink water, drink water, drink water. And some people go way above 2 liters of water per day. And if you're drinking more than you need, you're definitely going to be urinating more because what goes in does come out. And so that's one thing to take into account. The other thing that they mentioned was this up to 2 liters was also considering the liquid in the foods you eat, not just what you drink as a direct fluid. As far as caffeine, the recommendation was just 1 8 to 10 ounce caffeine per day, maximum per day, so that you don't overdo it and irritate the bladder. The caffeine also includes the chocolate, even though I'm a chocolate lover and I technically say that it's not caffeine, it's theobromine, which acts like caffeine, but anyway, we're not off on a soapbox. Up to 1 alcoholic beverage maximum at night, referring to at night before you go to bed because of causing a couple things. More urination at night because it's a diuretic. Also sleep problems because with alcohol you tend to get sleepy and go to sleep easier, but you tend to wake up in the middle of the night. And so that's a problem that you don't need with Parkinson's. The reason it says usually wine is because beer, for the amount of alcohol it has in it, beer is a larger volume. It's a more dilute alcohol. And so adding that volume at night before you go to bed is not helpful. Salty and spicy foods can lead to fluid retention, which then when you lay down at night, your kidneys have to filter off. And if you do have a problem with urination at night or nocturia, then some things to consider avoiding in the evening. One of them is the 2 liters of fluids that you're going to drink per day. Drink it earlier in the day. Drink it all morning. Concentrate on drinking all afternoon. But by, 4 o'clock, 6 o'clock p.m. after dinner, try to have all your drinking done so that your kidneys can already be flushing it out before you go to bed. Diuretics, sometimes people are taking a diuretic pill at bedtime, and that's just going to exacerbate having to get up repeatedly at night. This is a list of, again, from the University of Colorado, their Eurogyne website, and it actually mentions some differences in wines. So if you are really a wine person, a low tannin wine is much more gentle on the bladder. And that includes things like the Zinfandel and Merlot and Pinot Noir. So things like Cabernet Sauvignon, try and avoid that because it's going to be more irritating. There are medications for overactive bladder. There's probably about a dozen of them, and I do not know all the nuances of them. So I'm just going to give you this generality of the whole anticholinergic category. The main side effects are drying you out. If you're having too much urination, the anticholinergic dries everything out. Your mouth gets dry, your eyes get dry, and dry eyes can be more blurry. It constipates you more, and it also has cognitive side effects, which can exacerbate or cause confusion and hallucinations. If the anticholinergic works too well, you're going to have a problem with urinary retention. One of the anticholinergics I will mention is the newest one. It's Toviaz, and it's brand name only, of course, but some of the insurances are covering it. But it actually has no cognitive side effects, even in elderly people that are at risk or on the verge of cognitive problems. So it still has the dryness problems, but it doesn't have the cognitive problems. The other newer medication is Myrbetriq, and its side effects are a slight increase over placebo in the amount of headaches and a mild rise in blood pressure and heart rate. Those aren't great rises, just mild, but it's something that the doctor needs to be aware of when they prescribe you this medication. The advantage of Myrbetriq over the anticholinergics, one is that it doesn't cause the dry mouth or constipation problems. It also doesn't have brain receptors, so you don't get the confusion problems. And it's less of an issue of having urinary retention. The PTNS, if you've tried the medications and they haven't worked for you, or you haven't tolerated them, or if you want to avoid medications because of their side effects, percutaneous tibial nerve stimulation, or PTNS, can be done by mostly I know of urologists doing it, but there might be other clinics as well that have this capability. Basically, they use a tiny handheld device that has a wire with a small needle, similar to the size of an acupuncture needle, and it is placed in the ankle behind the medial ankle bone. It is turned on, and when it's turned on, it delivers little electrical pulses through that needle to the tibial nerve in the leg. That tibial nerve does not control the bladder, but it is hooked back up at the spinal cord area with where bladder control is. So it modifies the control of the bladder, and it helps with symptoms. This procedure would be done for a 30-minute session. once a week for 12 weeks. After about 5 to 6 weeks is when you might start seeing benefits. Sometimes people see benefit earlier, sometimes later, but average is about 5 to 6 weeks before seeing benefit. After 12 weeks of doing it, if things are better, then you might just go on a once-a-month maintenance phase. As far as whether it hurts, it more feels like a buzzing in the leg, and it kind of makes your toes fan out a little bit because it's stimulating it makes the muscles kind of tighten up a little bit in that area too, but it's generally not considered painful. So that's an option that doesn't have any of the side effects of the medication, and it's not a permanent thing. It doesn't prevent you from going out and getting an MRI scan, which one of the others does prevent you from doing. It's the one after this one. So the next thing is Botox injections into the bladder. And I've seen mixed reports on this as far as how often it's used in Parkinson's disease, but I do have patients that have tried it for overactive bladder. Now, again, this muscle up here is the one that gets overactive. It spasms before the bladder is completely full, and that's what gives you the urgency and might make you leak. And so what they do is they put this flexible cystoscope into the bladder, and on the end of it, it has a needle, and they puncture the wall of the bladder about 20 times to inject Botox into the wall of the bladder. Botox, it's the same Botox used for facial wrinkles, so you can always ask the urologist if they have any left, if they would do your eyes and your mouth. but anyway, it disrupts the signals from the nerves to the muscle so that spasming calms down. The good and the bad of it is that it's temporary. So if you go in and get this injection, it might be effective for up to 6 to 9 months, but eventually the effect of it is going to wear off. And so then you'd have to decide, is this bad enough again that now I need to do it again? The other problem, if they were to inject too much the first time, then you could actually get a weakness of that muscle to where it can't empty properly, and you have retention with the urinary tract infections like we talked about earlier. This one is another nerve stimulation device. The brand name is called Interskin, and it's by Medtronic. So it's similar to a pacemaker for the heart, or in a way similar to the pacemaker for the brain, the deep brain stimulation. But the wire in this case is in the S3, the sacral, by the sacral third nerve root, and it gives stimulation to the control centers of the bladder to again try and help. Before they actually implant this device, they would put in a temporary wire with an external control that you could, before they do the surgery and put the battery in, they would just have it as an external control to see if it works for you before they go and implant that battery. Because once they implant the battery, it is preventing you from getting an MRI scan because of the magnetism. So you wouldn't be able to get an MRI. I am aware of a couple of my patients that have had this, and just of those couple, they haven't had great results, but again, it's probably a case-by-case basis where any of these, you want to do it in the right person to get good results. And so making sure that it was done in the right person, it was done correctly and all that. So now we're going to talk about where the rubber meets the road. What's available to take care of leakage if I still have leakage? Of course, there's the diapers that are disposable, and there's either pull-ups or there's ones that are adjustable. These may not, if you want to have something that looks nice, there are actually ones that are very lacy and racy. So you can find those online now. This lacy one also, it's it's a material instead of a plastic type thing. It's a washable. It's washable. Then you've got various sizes. There's all kinds of sizes and shapes of pads. These are some pads. This is a pad especially for men. And then for nighttime, if there's leakage at night. So if your brain doesn't wake you up when you have the urge to go and you have a full-out bladder leak and it overflows, you end up having to get up at night to change your bedding repeatedly. Well, something like this is a disposable pad that can go on the bed, and it soaks up whatever whatever overflows. There's also, again, washable, reusable ones of bed pads. So those are all available. A toilet riser with handles can really help if somebody has difficulty with mobility around the toilet area, getting down on the toilet, getting back up from the toilet. There are bedside commodes where you can, if it's too far to get to the bathroom, you can keep a commode next to the bed and use that overnight. There's also urinals that men, and even urinals for women. This one has like a funnel type thing on it that's more designed for women. So there's urinals that you can keep by the bedside. Some people may still need to actually stand up to use the urinal. Others can train themselves to be able to go while lying down or sitting on the edge of the bed. A condom catheter is kind of just like what it sounds. A condom that leads to a catheter bag. This is an older version. I would say it's older because now they have adhesive ones, which all these others are examples of adhesive ones. So this older one, you actually have to use a belt to hold it in place. It could be used during the day where the bag is hooked to your leg, like this guy, or you can use it at night where the bag is hanging on the side of the bed. And so if you have to go, you just keep lying there and you just go and it urinates into the bag. This one, using this particular non-adhesive one at night is going to be much more a problem with leakage. These adhesive ones are, let's see, this is one that's not yet deployed, shall we say. That's what it looks like coming out of the package. And similar here, this is not yet deployed. So this little strap here is a handle to pull on, and what you would do is you place it in position, and you pull that handle, and it rolls the sheath into position. And it's got an adhesive in this whole area, so it's tight, and it's good contact with the skin. It doesn't leak like this one might. These are really good for overnight or daytime use. They can apparently be used up to 24 hours at a time. There's even sport models, which are a shorter one instead of a longer sheath. It's got a shorter sheath. A good way to help get this off is, because of the adhesive, is to do it in the shower. So in the hot water. I just want to check. Oh, okay, never mind. I think somebody just, can you still hear me okay?
We can.
Okay, I'm just checking because it was saying like switch calls, like somebody else was trying to call in. So taking off in the shower. One of my patients, the wife actually helps her husband put it on and take it off. And she likes to just wrap a warm washcloth around it and let it sit there for a minute, a couple minutes. And then it just pulls off real easily, and she wipes it down and dries it off, and you're good to go. And they find it very convenient. The last thing I'm going to talk about is skin management. The biggest thing to know is that adult urine is not like baby urine. It is much more concentrated, much more alkaline than baby urine, and therefore it is much more caustic to the skin than the urine of a baby. So even if, somebody's had kids and they have a certain threshold of changing a diaper on the kid, for adults, you want to use a different threshold. In general, it's better to use a cleanser that's specific for urinary and fecal incontinence for urine and feces on the person, because those specialized products are able to gently cleanse and protect the skin, and they're just far superior to water. If you just use, say, a washcloth and you end up having to scrub, you probably already know that skin, the older you get, is more fragile. And even with minimal scrubbing, you could tear the skin, and that's not a place where you want to be tearing the skin. So getting some official cleansers would be very helpful. In essence, they're non-irritating, non-drying. They have special ingredients that help to gently remove the dried fecal matter. And they can either be ones where you have to rinse it afterwards, or ones where you do not have to rinse it afterwards, where you just use it and then you don't have to wash up. The next step after cleansing the skin is to condition the skin, either with some kind of a skin cream or a barrier ointment or a barrier spray. The skin cream itself is good for conditioning, but it doesn't create that good barrier you need for the next time you get urine or feces that's leaked out. And in a way, sprays might be better than ointments, because the ointment, you have to rub it on again, and again, if the skin is fragile, then it could tear. The last thing is just to try as best you can to keep the skin dry. And so that is the end of what I have. Let's see, do we open this up to questions, or what do we do?
Yes, questions. And
okay.
I have some that people have been sending in. So,
okay.
Wow. It's such a, you think it's so complex and can have so many consequences. So thank you and that was an amazingly comprehensive presentation. Someone said, can you repeat, how can I tell if I have a UTI and how can I prevent it? I know that was kind of at the beginning. I think that's important.
So some symptoms of having a UTI, one of them is just looking at the urine itself. If the urine is cloudy, if it smells stronger than usual, if it's darker than usual, those are symptoms that it might be a UTI. The other thing is, what consequences is it causing? Are you having new onset, urgency, frequency, or incontinence that you didn't have before, or a sudden exacerbation of the symptoms you had before? All those things are suggesting, oh, something's different. I need to check it out. It could also be just exacerbation of the cognitive function, like somebody, all of a sudden they got confused the last 3 days. They've been confused or hallucinating. So those are some of the ways you can tell without a urinalysis that I need to look for UTI. And then what was the other one? How to treat it?
Yeah. Go to the doctor.
So, basically it's call the doctor. They will check the urine and look for UTI. They may go ahead and culture it too to make sure that the antibiotic that they use is the right one. And for antibiotics, it's always important to use the whole thing up. If you just use, say it's supposed to be 7 days and you only use 4 days because your symptoms are gone, the symptoms might be gone, but the bug might not totally be gone. And so it might grow back with more force, stronger.
Okay, very good. And there was another question about how can I tell in my spouse, but that visual, that's a perfect way, no matter who it is, a good way to tell. George wanted to know how DBS affects urinary retention.
That is a good question, and I did see some things about it as I studied for this, because this isn't my area of expertise. And if I recall, I saw some things both ways. So I think I can't answer that. I don't think the final say-so is out on that issue.
Okay, got it. Question about food irritants. Are tomatoes on the list because they're acidic, or is it the entire nightshade family, like eggplants, peppers, etc., that are irritating too?
It said tomato products. Most things I've said have said tomato products. So I don't know if other things in them, like the lycopenes or anything like that, contributes. But certainly, anything that's acidic is included. To look at that more specifically, you could try Googling, is the whole nightshade family a bladder irritant or not?
Okay. And then this will be our last question. Should I see my neurologist if I have Parkinson's and are experiencing urinary dysfunction, or my primary care physician, or a urologist? Good
question. So as a neurologist, I generally ask about these things, but if we do think somebody has a urine infection, I'm in a clinic by myself and don't have a lab or resources to test for it. So I generally do refer them back to their primary to actually get the urinalysis done. If there's problems with the incontinence and the urgency and frequency that might need medications, especially if they have a urologist, I'll refer them back there because they know the different medications better than I do. But every urologist and every primary doctor is different on what their comfort level is with these things. I'd say it might be good to just say you don't know what to do. It might be good to just touch base by calling the primary doctor first and see what they think. Is it something they can deal with, or would they refer you to a neurologist?
Got it. And did I see someone raising their hand? I never know if people are just stretching or if they're raising their hand. If you're raising your hand, really wave it along. So the screen name says Teresa. So go ahead.
That's my wife.
You don't look like a Teresa, sir. But
no, I'm not. She's the one that logged on. That's why her name is up there. But I have a question. I was diagnosed with prostate cancer about 6 years ago, about a week before I was diagnosed with Parkinson's. Now, I had radiation on the prostate and it cured the cancer. So that's the good news. The bad news is that it left me with major bladder problems, urgency, and not just the bladder, the colon as well. So I have issues on both ends. Mm-hmm. After the urologist found out that I had Parkinson's, well, let me back up a second. First, he said I had radiation proctitis. Then he found out I had Parkinson's and he changed his mind. He says, oh, that's because of the Parkinson's. Because I felt like he was relieving himself of the responsibility of telling me anything about the bladder. You know what I'm saying?
Mm-hmm. Yeah, I kind of suspect, I would say life isn't black and white, life is gray. And so it's probably a combination. I'm sure the radiation, because typical Parkinson urinary symptoms, well, first of all, how long have you had Parkinson's?
About
more or less than
6 years.
Okay, so typically people with Parkinson's, the bladder problems don't start in the first several years. The bladder problems are a later symptom, and you've already had those symptoms starting right after the radiation. So it's probably a combination of both. With men do have these specific problems after having the TERP or the radiation, and so there's going to be extra problems with leakage, not being able to hold properly. But just going through this whole list of things, what can I do? If you can address any of them and fix any of them, it's not going to solve the problem because that's not the only thing going on, but it will help the problem.
I recently saw my urologist a couple of months ago, and he told me basically there's nothing he can do for me. I just feel like he's just washing his hands of the whole situation and go see a neurologist or something.
Might be good to see another one, see a different one. And therapists, physical therapists can do a lot of training on bladder control, the Kegel exercises. Some of them might even know on what it was called, I guess it's the bladder training for techniques. So that can help.
That's my biggest issue right now is the urgencies on both ends.
And I think physical therapy isn't always the obvious, the intuitive answer. So that's a great reminder that they do have, techniques and that whole protocol strategy, whatever, that can help. So that's great advice. And I think too, if your urologist, like Dr. Reed said, if he wants to wash his hands, you wash your hands of him, and maybe that's a time to look for another provider.
Well, the problem with
right?
the problem with that is he's the only neurologist in my. I'm a veteran, and I go to the VA hospital, and there's only one urologist at the hospital.
That can be a problem. Also with insurance plans, as insurance plans change year to year, you end up getting bumped from doctor to doctor. So
Right.
Sometimes geography too.
Mm-hmm.
But, some good, maybe some other things to try. Well, I took 3 pages of notes, Dr. Reed. Thank you.
Okay.
Super comprehensive, and a lot of practical tips, things to watch out for. So thank you so much to Dr. Reed for volunteering her time to share all this with us. This is going to be, the recording's going to be up on our website. I bet this is going to be one that some of us might want to rewind through and rewatch and get some screenshots. So give us a couple days to get that on the internet, and keep an eye on your email and our Facebook. We'll notify you when we get that up there. That wraps up today's Lunch with Docs. Thank you so much for joining us, everyone. Quick note, we're coming up on the holiday season. So the 4th Wednesday falls right in the middle of, right before Thanksgiving, and then also on Christmas Day. So we aren't going to be having Lunch with Docs for November or December, but we'll see you back in January. We do have, might be a good chance for you to check out some other NeuroLife online programs. Therapy Break is similar to Lunch with Docs, but it's with a physical therapist, OT, covering an aspect of Parkinson's therapy. So take a look at our website and our emails for more chances to join us online to learn, live, and connect. So thank you, everyone, for joining. Have a great afternoon. Bye now.
Thank you.